Thank you, Dave, for a very nice introduction. So we're going to switch gear a little bit, talk about this rare disease, hairy cell leukemia. So hairy cell leukemia that some of you guys may know is a rare chronic B-cell lymphoproliferative disorder that affects about 600 to 800 new cases per year in the United States. This is a lot rare compared to CLL we just discussed. It's characterized by this accumulation of the cells with this irregular cytoplasmic extrusions that's been seen in this the slide presentation here too. And the key clinical features of this disease include large splenomegaly. This is one of the few diseases or the lymphomas and leukemias that can be characterized by massive splenomegaly. And then these patients also develop cytopenias from bone marrow infiltration from these hairy cells, anemia, thrombocytopenia, neutropenia, as well as bone marrow fibrosis. And because of that, a lot of times the initial bone marrow sample will be inaspirable due to significant amount of fibrosis that these patients get. And the key molecular features, which we'll talk in much more detail later on, is the presence of this BRAFV600E mutation that's present in over 90% of the time in hairy cell leukemia patients. And then the MAP kinase pathway, which is the RAF-MEK-ERK pathway, is constantly active in hairy cell leukemia, which provided a rationale to targeting BRAF in hairy cell leukemia. So just to show some of the pictures, as I mentioned before, the massive splenomegaly, pancytopenia, and then characteristic, the immunophenotypic type is the positive B-cell markers, including CD20, and CD25 is kind of the one marks as a classical hairy cell leukemia, and in the end, we'll briefly mention hairy cell leukemia variant, which is a related disorder, which is actually marked by the CD25 absence. And 11C positive and 103 positive is kind of the one makes the diagnosis of hairy cell leukemia, along with the morphological the presence of those hairy cells. And the main problem these patients get, similar to the CLL patients, is infectious complications from progressive cytopenias. So what is the standard or the current paradigm of the first-line hairy cell leukemia treatment is the treatment with a purine analog, such as cladribine or pentostatin. And there have been many clinical trials, single-arm studies, showing the significant benefit of the cladribine, which is usually given either 5 or 7 day infusion, just one infusion of cladribine, or a series of infusion of pentostatin, which usually lasts about 3 to 4 months of a therapy, can yield a response rate of 60 to 80% complete response and 10 to 20% of the PR, which means almost everybody will benefit from this type of therapy. However, that about 30% of the patients, despite the initial good response, will relapse. Each time they get the repeated course of a treatment, which there are not a lot of therapeutic options available previously, that duration of the treatment will decline with the further treatment these patients may get. And then one of the reasons that these patients may relapse despite the initial high response is the evidence of the MRD or the minimal residual disease and then activation of the MAP kinase pathway that is evident in these patients who have a subsequent the treatment. And then for those patients who have repeated relapses, more than 3 relapses, and these patients have very limited treatment options. And it just provides, despite the very high response rate in rare disease, and because of that, there's unmet need for those patient population who have a refractory or multiple relapse patients. And then what about the cladribine and pentostatin also have its own side effects too. These agents are known to cause second malignancies and infections. And this is the data from gathered together from the cladribine, which is a 2-CDA, and then 2-DCF, which is a pentostatin data, reporting the second malignancy rate ranging from 7.5 to 20% in these patients. And it's always hard to tease out the second malignancy in hairy cell leukemia because, as you guys are fully aware, that having this indolent B-cell malignancies or immunocompromised state in itself can increase the risk of second malignancies. And it's unclear how much is really derived from the hairy cell in itself or the treatment these patients get, the cladribine and pentostatin. No matter what the etiology may be, the combination of these agents and the risk of second malignancy is not insignificant. So where this BRAF really came from, one of the first reports really came from the group in Italy, Tiassi and Fellini et al. That was published in New England Journal of Medicine in 2011. They did an exome sequencing of a single hairy cell leukemia patient and discovered that that patient harbored the BRAFV600E mutation, which was a well-known mutation in a variety of different cancers, including melanoma, and there was an already existing drug targeting BRAF that was approved for melanoma around that time. And they subsequently went back and sequenced more patients, 54 patients, and then they found that 100% of these patients all carried the BRAFV600E mutation. And then they also tested the other cohorts of related or other indolent B-cell malignancies, and they did not find those mutations in those subsets, arguing that BRAF somehow was involved in pathogenesis of the hairy cell leukemia. And other groups with a slightly different method of and then confirmed this high presence of BRAFV600E mutation. Over 500 cases now that have been sequenced, and then all validating the very high, nearly universal presence of this mutation in hairy cell leukemia. And they also tend to track with the disease. They're present at the time of diagnosis, and then they seem to go away with at the time of treatment, and they also the relapse. At the time of relapse, these mutations recur. Also, another evidence that not only the presence of the BRAF mutation is that, as I mentioned before, the MEK kinase pathway also seems to be activated in hairy cell. That was also known before. This is another data that from the same group that reported the BRAF mutation, the ubiquitous, the phosphorylated ERK expression in hairy cell leukemia in the bone marrow. Again, evidence the MEK kinase pathway, along with the BRAF mutation, is involved in the hairy cell leukemia pathogenesis. Our group, and with the collaboration with Omar Abdul Wahab at MSK, then further looked at where this mutation occurred. The cell level origin for hairy cell leukemia, it remains to be unclear that whether the mutation occurs in the mature B cells or in the early in the progenitor cell stage throughout the B cell development. So the Omar's lab, and along with the Steve Chung at MSK, we sorted out the cells from the hairy cells, and it's from the various primitive stages of the hematopoietic stem cells to all the way to the mature B cells and the hairy cells, to really find out, now that we have this tool, where this mutation occurs. And I found that the BRAF mutation actually happens in the very early, the hematopoietic leukemia initiating cells. Again, arguing that this is involved in pathogenesis, and if you were to target this mutation, perhaps that you'll reduce the relapse rates even in the frontline setting. So again, this is a summary of the rationale for targeting BRAF. We already explained that this mutation is highly prevalent in patients with the classical hairy cell leukemia. The pathway seems to be activated. This mutation occurs very earlier on in the development, biology of the hairy cell development. So that argues for the targeting BRAF. And there are many the different BRAF inhibitor agents that's present. So they provide a rationale for, in a German group, to try the Vemurafenib, which is a known BRAF inhibitor in patients with a patient with a refractory hairy cell leukemia. This is a case report that was first published in 2012 that showed in the patient who got limited duration of Vemurafenib had a quick reversal of the cytopenia and then splenomegaly, the benefit. So along with the preclinical data and the genetic information and this clinical information is what prompted us to initiate the phase 2 clinical trial with Vemurafenib, which is the BRAF inhibitor in the relapsed refractory hairy cell leukemia patients. And the trial was actually conducted both in Italy and the US concomitantly. The Italy is the same group that reported the presence of BRAF, and then MSK, along with the other sites, including Dana-Farber, participated in the US multi-center studies, which we published the results in 2015. The study design from the U.S. centers, and I'll kind of highlight a little bit differences in the Italy study and the U.S. study. There are subtle differences, but overall, they're very similar. The phase 2 studies, the primary objective of our study was looking at the overall response rate and the key eligibility criteria, because these patients tend to respond pretty well to the repeated course of the cladribine despite those toxicities. That we included patients who are intolerant to purine analogs or fail to achieve any response to the initial purine analog-based therapy. So true refractory patients, which is very rare, or the patients who have a very early relapse after initial purine analog-based therapy. So we define that as if you relapse within 2 years of your first-line therapy, even when you repeat the same course of the cladribine or pentostatin, these patients tend to not respond very well. And the patients who had more than 2 relapses also qualify for this study. And similar to CLL, there are certain criteria that make us to initiate therapy. So these patients also need to have some degree of a cytopenia, which we define as ANC less than 1, hemoglobin less than 10, or platelets less than 100. So this is a schema of the treatment for the U.S. study. So we had a study, the patients took 960 milligram twice daily, which was actually the dose that was used and that led to approval in the melanoma patients. So same dose for 3 months. At the end of the 3 months of the study, that we repeated bone marrow biopsy to assess response. And depending on the quality of the response they got, meaning the partial response or MRD positivity, the measure by either the BRAF allele burden or the biopsy by immunohistochemistry, these patients were allowed to receive further course of Vemurafenib for additional 3 cycles for a total of 6 months. In the Italian trial, the only difference was that they treated patients for 4 months instead of the 3 to 6 months in our study. The results are very similar, though. So this is a baseline characteristic from the paper, which may be a little bit hard to tell, but again, this just highlight the point that these are high-risk patients, and they also include some of the patients who had prior splenectomy for their disease. This is one of these sample slide for the response kinetics, just to show that the patients actually tend to respond very early. In this study that we are doing the peripheral blood flow once a week, because we actually didn't know when we initiated a study how quickly these patients would respond, how these agents will work. The hairy cell tend to go away very quickly, even after 24 hours of a treatment, just 2 doses of Vemurafenib alone. And also the cytopenia recovery, or the normal count recovery, happened about 30 days into the therapy that these patients recover their counts to a normal range. And also, as has been shown by the flow cytometry here, and the hairy cell tend to go away within kind of the 1 to 3 months of a therapy in the bone marrow also. So summary of the clinical outcome of the 24 patients from the US side of the story, which was actually very similar in the Italian study, was that 100% of the patients responded. Majority of these responses were partial response. In our study, we saw about 40% CR and a 60% PR. Italian study CR rate was slightly lower at 35% or so, but very similar. So in essence, 35 to 40% of the patients achieved a complete response, which is a complete eradication of the morphologic hairy cell leukemia, and then the partial response is evidence of the disease, but with a full recovery of their blood counts. But I should also mention that even in the complete response patients, the vast majority, almost all patients had some degree of MRD. So if you look harder with the BRAF allele burden or the immunohistochemistry, we are always able to detect some degree of the leukemia cells. And this is a survival curve, which these patients tend to do fairly well, just similar to CLL, although the repeated or super refractory patients, not as much. But this is showing, again, the kinetics of the relapsed hairy cell leukemia fairly early on in 1 to 3 months of the disappearing the hairy cells by the morphology and also by allele burden on the last the graph. And this is just kind of one of the markers. There are certain inflammatory cytokines that tend to track with the disease of a hairy cell leukemia. This is showing that those markers also decrease with the treatment with the Vemurafenib as well. So Vemurafenib, the side effects is well known from the melanoma data, and then our experience has been very similar as melanoma patients too. The rash was probably the most common side effect these patients experienced, along with arthralgia, some alopecia, and the photosensitivities, and the squamous cell carcinoma, which is also another known side effects of this therapy as well. So significance or the rate was not any more than what we'd expected from the melanoma patients. However, despite this huge, the very good, significant result that we reported, there are some remaining questions. So optimal dose, we mentioned before, adopted the same dose that we have used in melanoma patients, but it is actually unclear whether the same dose, that high dose, is necessary for hairy cell leukemia. Obviously, the CR overall response rate 100% is higher than what we get with the melanoma patients. That also suggests that do we really need that high dose to suppress this hairy cell leukemia? That can we do a lower dose? And there have been some, no clinical trials, but anecdotal experience have been reported recently in blood by German groups. A series of the case reports put together, the doses as little as 240 milligrams, so 1/4 of the dose, may be effective in treating these patients, not getting into CR, but enough to reverse their cytopenia. And also the duration of this therapy is unknown. As I mentioned before, in our study, it's about 3 to 6 months of duration. Italian study is 4 months. At the end, these patients all stopped the study. It stopped the drug, and it was observed. And whether they need to continue the drug continuously into disease progression, which is a similar model that a lot of metastatic solid tumors are adopting, or the certain duration, the limited duration of therapy may be sufficient, that we don't know because our study was not designed to answer that question. And also with the follow-up, because as I mentioned before, the CR, even in the CR patients, about 40% of the patients who achieved the CR, among that, if you look harder, that we are able to detect evidence of disease. And perhaps due to that, these patients also tend to relapse as well. So our relapse rate is about 30% or so that these patients will relapse despite initial great response. And then, interestingly, all 6 of the patients, and this is again our study in the US study, that when they're retreated with Vemurafenib, that most of those patients relapsed. However, the one patient became refractory or had acquired the resistance, and that kind of provided information as to the next step that we're going with this study. So this is Omar's the data kind of looking at the variety that prompted us to look at all genetic landscape of the hairy cell leukemia, and that we were previously unable to do that. It's a rare disease, but clinical trials actually allow us to gathered the human samples from these patients to sequence with the targeted gene sequencing that Omar's lab employed, looking at 300 to 350 genes, looking at what are the common mutations that occur in hairy cell leukemia in addition to BRAF mutation. And that showed that there are some mutations that occurred, including the MLL3 copy genes that's well known to occur in other B-cell malignancies too. So what about that acquired Vemurafenib resistance? So we applied the same genetic sequencing for that particular patient. There's a 77-year-old guy with a very complex karyotypes and multiple therapies. He initially had a partial response, but quickly after stopping the drug, about 2 months after, his disease relapsed. And this is showing the hairy cell leukemia burden from the peripheral blood from the initial duration of therapy for the 6 months. While being off of it for about 2 months, his disease came back, as shown by this graph, as well as his splenomegaly. And he got retreated with the Vemurafenib, and he had a very transient initial response, going the hairy cell leukemia burden going down, but quickly became resistant and underwent splenectomy, but despite that, unfortunately, he passed away from progressive disease. And this is just flow diagram showing the disappearance of the hairy cells and reappearance of the hairy cells at the time of the resistance. Interestingly, this patient actually acquired the KRAS mutation, which is well known, acquired the resistant mechanism in BRAF, the targeted therapy in melanoma, and that appears to be true in this one particular patient. And then we also had a de novo resistance in the Vemurafenib patients as well. So not only so we had one patient, 100% of the response I mentioned before, but there was one patient who got the therapy for about 2 weeks and unfortunately died from infectious complication that he already had at the time of study enrollment. So pretty bad disease and a kind of bad subset. So he was not part of the initial evaluation set because he didn't complete the 3-month therapy, but that data actually provided an evidence of the novel mechanism resistance in the particular patient, that he didn't have a KRAS mutation, but he had an IRS1 mutation, which is another way that this, the MEK kinase pathway could be activated, as well as the AKT signaling pathway. So without, to the limited time, I won't go into too much details, but this is just to show that the other mutations can, as expected, coexist at the time of the Vemurafenib treatment. This is all relapsed patients or on therapy. These patients can they can relapse with acquired resistance. So where are we going with this therapy, and what other therapies are available for hairy cell leukemia? So Vemurafenib or the other BRAF inhibitors appears to be highly effective in patients with relapsed refractory disease who have failed or tried the cladribine or pentostatin, which is now considered to be the standard therapy. There's a recent data from the same Italian group, the Tiassi et al., and that was presented at ASH 2016. They combined the Vemurafenib plus rituximab, which is another, it's a CD20 targeted monoclonal antibody that's known to work in hairy cell leukemia as a single agent as well. And because of the MRD positivity, they combined those agents together to see whether they can get a better response, and appears to be so. The CR rate, as opposed to 35% what they reported in their single agent phase 2 study with Vemurafenib, now they are seeing the 100% CR rate. Although the sample size is small to 14 patients, the response rate is encouraging. So once you add a CD20 targeted antibody, that you may hopefully able to overcome the resistance mechanism and get into CR rate, and that will translate into less the relapse rates. So that approach is now being, they have obviously ongoing study is in the relapse refractory setting. In our study, the MSK and along with other centers, we're taking that approach to moving to the frontline setting. So instead of the cladribine and pentostatin, so we're moving Vemurafenib with another anti-CD20 antibody, obinutuzumab, in the frontline hairy cell patients to see whether we can, they respond very well, the 100% response rate overall. So we are targeting the similar CR rate about 70 to 80% with those two agents, with an idea that hopefully we can reduce the second malignance rates with a short duration of a therapy of the Vem plus obinutuzumab, and as well as the immunosuppressive suppression that the cladribine or pentostatins are associated with. So that's about to open about 3 months from now in different multicenter studies in the US sites. The another approach is the RAF plus MEK inhibitor, which is an approach that's been taken by melanoma, the patients as well. And that has been done. There's no dedicated hairy cell leukemia trial because it's a relatively rare disease. It's hard to do those trials, but there was a basket trial that combined the BRAFenib plus trametinib with encouraging result, kind of overcoming the resistance mechanism of single-agent BRAF inhibitors is ongoing as well. And as probably aware, the another anti-CD22 immunoconjugate moxetumomab that was developed at NCI has shown very promising results for many years. The overall response rate of 86% with a high CR rate in the relapse setting, and that was published by Dr. Kreitman at NCI. And ibrutinib, we talked a lot about them in the CLL, also shown to be active in hairy cell leukemia, perhaps not as much as a BRAF inhibitor, but they were able to show in the Ohio, the lead study, in 28 patients, the CR rate of 14% of the patients who are these refractory patients too. So lower than what's appeared to be we can accomplish with Vemurafenib, but nonetheless still encouraging and present another option for these patients. So just one slide, the last slide is a hairy cell leukemia variant, because this comes up rarely, but it's important to point out that all the data that I presented for now is a classical hairy cell leukemia. Again, the presence, which is characterized by presence of BRAF mutation, as well as CD25 expression. So hairy cell leukemia variant, that you do not have the BRAF mutation, also you do not express CD25. That's one of the ways that you can make the diagnosis, but clinical presentation could be very similar. But however, the Omar's group, again, have sequences hairy cell leukemia variant, and we found out that in about half of those patients carry the MAP2K1 mutation, which is involved in the hairy cell leukemia, the MEK kinase pathway. So we are targeting also with the ERK inhibitor that may work the hairy cell leukemia variant, which actually these patients have a very little treatment options. We are using cladribine for these patients or pentostatin, but majority of the response that we get is all PR, never CR, and even when they respond, the response duration is very short. So the ERK inhibition in hairy cell leukemia variant may represent another promising therapy for this. So in summary, the hairy cell is characterized by a number of genetic alterations, as we reviewed before, in addition to BRAF mutation, which is highly prevalent. The Vemurafenib, which is a BRAF inhibitor, is highly effective in this patient population with a relapse disease with a 100% overall response rate, but relapses do occur in about 30% of the time, and hopefully that we can overcome with a variety of combination agents and by moving these agents to the frontline setting, and also for the hairy cell leukemia variant for the ERK inhibition too. And this is work done by many different groups across the United States and internationally too. Thank you for your attention. Thank you.